Dear Chair, dear audience, I would like to present my presentation. My main topic is systematic treatment of metastatic prostate cancer. Firstly, I would like to summarize my first project, 6 sentences. The metastatic castration-resistant prostate cancer, it is a late stage of the prostate cancer and the overall survivor of 2 or 3 years. The abiraterone and the enzalutamide are two similar androgen receptor signal inhibitors, but unfortunately we haven't got clinical trials which treatment is better. Our meta-analysis, we show it that the enzalutamide, it's 21% better overall survivor and 85% better the PSA 50 than abiraterone. But when we see the higher adverse events, we show it that the abiraterone is better than the enzalutamide. Generally, we can ask that the first line treatment, we should use the enzalutamide, but we have got higher comorbidity patient, we have to know that abiraterone. In the future, it will be very important that we have got clinical trials, and it is important that health insurance system should insure equal these two drugs. My name is Anikó Varikovics. I work as a doctor in Semmelweis University in Department of Urology. My vision, the patient will have the best treatment option for metastatic prostate cancer, and my mission to find a drug that significantly improves the quality of life of patients. We have got 3 specific goals. The first project, investigating the efficacy and safety of abiraterone and enzalutamide in patients with metastatic castration-resistant prostate cancer. The prostate cancer, it is the second most commonly diagnosed cancer. More than 1.2 million new cancer cases, and the mortality it's more than 300,000 in a year. The metastatic prostate cancer median overall survivor of 30 or 35 months. The abiraterone and the enzalutamide, and it is a standard treatment in mCRPC, and both similar anti-androgen receptor signal inhibitors. No clinical trials are available for the direct comparison of their efficacy. The aim to investigate which of these two treatments is more effective in mCRPC. The clinical question, which treatment is more effective, abiraterone or enzalutamide for mCRPC. When we see the PICO framework, the population is mCRPC patient, the intervention is the enzalutamide, the comparison is the abiraterone, and the primary outcome is the overall survivor, and the secondary outcome is the PFS, PSA 50, and side effect. The hypothesis, the enzalutamide is superior to abiraterone in patients with mCRPC. The clinical implication, increased therapy efficacy in mCRPC patient. We have got only one search key domain. We use 3 databases, and after the 2-time selection, we have got more than 10,000 results. Now, I would like to present the primary outcome. It is overall survivor. This forest plot, we see first and second line treatment. We see 34 articles. We have got 2 lines, the enzalutamide and the abiraterone line. We have got more than 50,000 patients. Here we see that the hazard ratio is 0.79. It means that the enzalutamide it's 21% better than the abiraterone. The heterogeneity is high. It is a statistical significant results and clinical relevant results. When we see the PSA 50, the PSA 50 means that the rate of the PSA decreased higher than 50% under 3 months therapy. Here we see the first and the second line. We have got 18 articles. We have got 2 lines, the enzalutamide and the abiraterone arms. The odds ratio is 1.85. It means that the enzalutamide is 85 times efficacy than the abiraterone. The heterogeneity is high, but it is a statistical significant results and clinical relevant results. This project, there are some strengths and limitations. The strengths, it is a large sample size, 9 outcome measures, significant results. The limitation, the observational studies included, and there are some limited data for some outcomes. The conclusion, the overall survivor and the PSA50 rate are significantly better for ENZA. Overall adverse events are less frequent for ABI. Cardiovascular side effects are more favorable for ENZA, while the neurological adverse events are less frequent for ABI. The implication for practice, the ENZA showed superior efficacy and the ABI show more favorable side effect profile. The implication for research to assess and understand the mechanistic background of the superior effect of ENZA. We submitted the manuscript and last weekend we sent the Prostate Cancer and Prostatic Disease Journal. The second project investigating the efficacy and safety of abiraterone, apalutamide, and enzalutamide in patients with metastatic hormone-sensitive prostate cancer. For metastatic hormone-sensitive prostate cancer, the addition of an androgen receptor signal inhibitors to androgen deprivated therapy has become the standard of treatment care. No clinical trials are available for the direct comparison of their efficacy. 6 or 8 of patients are directly diagnosed with de novo metastatic hormone-sensitive prostate cancer in the USA, and 20% of patients with localized disease progress in metastatic prostate cancer within 5 years. To aim to investigate which of these 3 treatments is more effective in metastatic hormone-sensitive prostate cancer. The clinical question, which treatment is more effective, abiraterone, apalutamide, or enzalutamide for metastatic hormone-sensitive prostate cancer. The PICO framework, the population is the metastatic hormone-sensitive prostate cancer patient, the ENC, the apalutamide, enzalutamide, and abiraterone. The primary outcome is the overall survivor. The secondary outcome is the PSA90, time to castration-resistant prostate cancer. The PSA, it's lesser than 0.2 nanogram per milliliter and side effect. The hypothesis, apalutamide is superior to abiraterone and enzalutamide in patients with metastatic hormone-sensitive prostate cancer. The clinical implication, increased therapy efficacy in metastatic hormone-sensitive prostate cancer patient. We have got only one search key domain. We have got more than 11,000 results, and we work this project now. The third project to identifying patients with metastatic prostate cancer who benefit from PSMA radioligand therapy. The PSMA radioligand therapy, it is a new therapy option for metastatic prostate cancer. The prostate-specific membrane antigen, it is a transmembrane glycoprotein which is overexpressing in high-grade and advanced prostate cancer. The metastatic castration-resistant prostate cancer, which combines a PSMA antibody with different radionuclide included, perhaps the beta emittance, such as the lutetium-177. The clinical parameters for PSMA radioligand sensitive patient need to identified. The aim to identify the clinical and pathological parameters defining the most responsive patient to PSMA radioligand therapy. The clinical question, who do different clinical parameters influence the outcome of PSMA radioligand therapy in metastatic castration-resistant prostate cancer? The PICO, the population is the PSMA radioligand therapy, the ENC, the ECOG age metastatic localization, the primary outcome is the overall survivor, and the secondary outcome is the PFS, PSA50, and side effects. The hypothesis, the PSMA radioligand therapy provides greater overall survivor in advanced metastatic castration-resistant prostate cancer patient with specific clinical pathological characteristic. The clinical implication, the PSMA radioligand therapy may be more widely used in advanced in metastatic castration-resistant prostate cancer. In the end, I would like to summarize these 3 projects. The first project, investigating the efficacy and safety of abiraterone and enzalutamide in patients with metastatic castration-resistant prostate cancer, we submitted this month. The second project, investigating the efficacy and safety of abiraterone, apalutamide, and enzalutamide in patients with metastatic hormone-sensitive prostate cancer, we would like to submit it in year October. And the third project, identifying patients with metastatic prostate cancer who benefit from PSMA radioligand therapy. And the end, I would like to ask Helnin. Helnin asked that everything is theoretically impossible until it is done. Thank you for your attention.
Thank you, Aniko. Useful work. Your work covers ENZA, ABI, and apalutamide.
Yes.
And your work's not covering darolutamide. Why not?
Yes, because we would like to see a lot of a better group, and darolutamide, it is a newer treatment, and we haven't got enough information that we can take it in the second project.
You know, in CNS protection, it
Yes.
will be important in the next couple of years or decades. So maybe if you have enough information as a fourth project, please cover darolutamide. I would be very interested.
Yes, thank you for your presentation. I would like to ask regarding your first project, which type of therapy is more frequently used in clinical practice?
In Hungary, we use the abiraterone higher number than the enzalutamide. Because the financial protocol not it's better than enzalutamide.
Thank you.
I have just one question. You said that the treatment for the metastatic prostate cancer, it is possible, for example, primary cancer use this treatment or not? Just metastatic?
Just only metastatic.
Just only metastatic.
Just
Thank you.
only metastatic.